Hello, I'm Neil Spooner. I'm the chair of the Patient-Centric Sampling Interest Group, and I'm really excited to have you attend our monthly webinar for May. Today, we've got Kashif Anwari from University College London, Royal Free Hospital London, and Hannah Ging from University of Liverpool speaking to us. The title of today's talk is Microsampling to Monitor Conventional and Novel Biomarkers for Pediatric and Adult Nephrology Patients. Before we start with the presentations, just like to take a moment to thank the sponsors of the Patient-Centric Sampling Interest Group. Without their donations and their activity, we wouldn't be able to provide these webinars for free for you all to watch live and watch the recordings after the event. Just a reminder of the agenda. Again, I'm Neil, I'm doing the introduction. We'll then be having a presentation by Cash, followed by Hannah. During the presentation, if you don't mind submitting your questions through the chat function, and we'll hopefully have 10 to 15 minutes at the end where I'll be addressing these questions to Cash and Hannah. We'll have a little wrap up at the end. Just remember, this event is being recorded and will be available in a few days through the Patient-Centric Sampling Interest Group website. So enough of me talking. I'll stop sharing. And I'll hand over to Cash, and who is going to go first, and then later you'll be hearing from Hannah. So over to you, Cash. See you on the other side.
Thank you. Right, let me just share my screen. Fantastic. Can I just get a confirmation that you can see my screen?
Yes, we can see your screen.
Great.
You as well.
Fantastic. We just want to start off by thanking PCSIG, Neil and Co. For inviting myself and Hannah to deliver this talk titled Microsampling to Monitor Conventional and Novel Biomarkers for Pediatric and Adult Nephrology Patients. This is going to be a two-part talk, as we mentioned. I'll be presenting first on microsampling in relation to CKD, followed by Hannah presenting on the optimization of the microsampling workflow. We hope that by the end of this talk, you'll be able to appreciate some of the benefits associated with microsampling in comparison to conventional sampling methods in patients with CKD, learn a bit more about the processing methodology that's involved for dried blood spots, a bit about the comparisons between various dried blood spot devices that are available, and then finally an identification of biomarkers using microsampling techniques. So to begin with my talk, which is on chronic kidney disease and microsampling. Just a little bit about me. My name is Kashif. I'm a nephrology registrar, which means that I'm a kidney doctor based at the Royal Free in London. I'm also a PhD candidate under the supervision of Professor Alan Salama, associated with University College London. And I'm studying lupus nephritis and ANCA-associated vasculitis, which are inflammatory kidney conditions, and how we can use biomarkers to identify remission in these patients. For the purpose of this talk, my supervisors were Professor Alan Salama and Dr. Louise Oni, based in Liverpool. I begin with saying that I've got no conflicts of interest, but I've got a financial disclosure in that this project was at least part funded by funding from Kidney Research UK. So I guess a bit about this project and how I came into the sphere of microsampling. Obviously, everybody knows 2019, December, we had this worldwide pandemic, which wreaked havoc around the world. And consequently, we entered into numerous periods of quarantine and lockdown. Loads of workforces were looking at ways of remote working, including the healthcare sector, in an effort to minimize interaction with those that may be infected. We were looking at ways in which we can reduce the number of clinic visits. We were looking at ways in which perhaps patients could come in for having blood tests, and at a later date, via virtual session, we could perform a clinic. So around 2022, both Louise and Alan successfully secured a grant to explore the use of microsampling technologies in monitoring biomarkers in patients with CKD. I was fortunate enough to secure a clinical lectureship position and set about exploring this topic. So just a bit about chronic kidney disease. Apologies for those that know this in and out. This will be basic information. But chronic kidney disease, as the name implies, is a chronic condition, and it happens over a number of years. If we look at the pie chart on the right, there's numerous etiologies that can cause CKD, with diabetes and high blood pressure being the two commonest causes. Glomerular diseases or glomerulonephritis, in which we have inflammation specifically of the filtering units of the kidney, that affects less than 10% of all CKD causes. Unfortunately, CKD can be a silent killer because similar to high blood pressure, it's not until the later stages where you start getting end organ damage or serious manifestations that unfortunately things are too late. And that's when you start manifesting some of the symptoms. So as a result of uremia or high urea levels, you might have nausea, vomiting, itching, you might have taste disturbances. Acidosis can make people feel not so great. As a result of CKD, we can leak protein and blood in our urine, and that can cause nephrotic or subnephrotic range of protein leakage, which leads to fluid overload and ankle swelling, amongst other things. As far as blood tests are concerned, we categorize CKD into 5 main stages, and the EGFR helps us categorize that. You can look at this number as almost like a surrogate of a percentage. So 90 is obviously very good. And it's when we start entering the CKD 3 stages, in which your EGFR is 60% or less, that we start running into trouble. Like I said, it's the later stages typically where people start manifesting symptoms. So as a result, we're heavily dependent on some of the surrogates that we have in the form of biomarkers, both in the blood and urine, that will tell us that something is going wrong. So with regards to blood tests, we can look at deteriorating kidney function with raising urea and creatinine or worsening EGFR. We can look at people's dipsticks, in which we dip paper into people's urine and can identify the presence of blood in urine. Sometimes for specific conditions like glomerulonephritis, we can look to see specific antibodies that cause that problem. And the gold standard is always the kidney biopsy. But this basically involves putting a needle into someone, which is both invasive, uncomfortable, associated with risks, and therefore of limited applicability going forwards. And as a result, I hope I've impressed upon you the importance of surrogate biomarkers that are non-invasive to identify CKD. Just a bit more about some of the specific kidney conditions, because I'll be talking about this later on. Glomerulonephritis, as I mentioned, is associated with inflammation of the filtering units of the glomeruli in the kidney. It can be associated with a relapsing, remitting pattern. ANCA-associated vasculitis or lupus nephritis are 2 such conditions that can cause a glomerulonephritis. And in these patients, what we do is we can look at a number of biomarkers. So we can look at the antibody levels because these are autoimmune conditions. So this pathological antibody sometimes can correlate with disease activity. Similarly, in recent years, soluble urinary CD163 has emerged as a biomarker that's able to identify inflammation and able to point with reasonable sensitivity and specificity that patients are entering remission. Kidney transplant is obviously not a kidney condition, but rather a form of renal replacement therapy that is offered to patients who have later stages of chronic kidney disease. Those that receive a kidney transplant require immunosuppression to prevent rejection, but sometimes, despite our best efforts, patients can develop humoral antibody-mediated rejection. And one such biomarker that we can use to identify patients at risk of developing antibody-mediated rejection is the presence of donor-specific antibodies, DSAs, or HLA antibodies. So that brings me on to microsampling, which essentially has been around for a long time, at least commercially since the 1960s, as an alternative method of sample acquisition and storage. Now, Hannah has pointed out to me recently that typically involves sample volumes of less than 50 microliters, but at times volumes higher than this have been used, which I guess in a grand scheme of things, in comparison to traditional venipuncture or traditional sample collection methods in which we're taking multiple milliliters worth of bloods, even 250 microliters is, in a relative sense, micro, quote in quotes. The most common or well-known example since the 1960s that we've been experiencing in the form of microsampling has been dried blood spot tests. The figure that we have on the top right, which have been used in the form of neonatal pediatric screening to identify inborn errors of metabolism. Now, these dried blood spots are great if the analyte that we're looking at is not affected by hemoglobin concentration or hemolysis. But if these two factors in particular do affect the analyte that we're looking for, there's a need for added logistics and associated costs. So what you need to do then is you need to spin the sample of blood round, and the supernatant thereby needs to be stored in -20 or -80. And like I said, these are associated additional logistics and costs. So around the time that we submitted and successfully retrieved our grant for microsampling devices, we came across this company called Biodesics that exists in the United States. They market themselves as an AI-driven data solutions company that had recently acquired a patent for a novel microsampling blood collecting device, which is shown in the bottom right, figures A and B. This was a device that used the principle of lateral flow to separate the cellular and the non-cellular components of blood. The device itself was relatively simple. You basically had a filter paper, which was enclosed in a two-doored cassette. On one end, you would place 250 microliters of your blood sample, and there was a mesh also to ensure laminar distribution of blood and to prevent large molecules from going forward. Eventually, what would happen is the non-cellular, the plasma component, would migrate forward. Some cellular components would go through to a certain point, but after that, there would be no further cellular material, or at least that's what was hoped. This device had been tested and shown promise in patients that had lung cancer or suspected lung nodules, to suspect that there may be potential cancer, to be performed in those patients with regards to proteomics. So intrigued by whether this device could be used for the first time in adult nephrology patients, both to look at blood and urine as a biomarker, we set about our project. So the population that we focused on in this project was those that have glomerulonephritis and those that have had a kidney transplant and are at risk of having high levels of HLA or donor-specific antibodies. The intervention that we compared was the use of the Biodesics device in comparison to traditional methods of sample acquisition. So this included traditional venipuncture, but also traditional means thereby of processing the sample within our in-house laboratories. The other comparison was urine, in that we used the Biodesics device to acquire urine and separate out the cellular and non-cellular components. And on these samples, we performed ELISAs to look at urinary CD163 and compared these results with whole urine that had subsequently been spinned down and put into an ELISA plate. With regards to our transplant population, because the aforementioned biomarkers are mainly looking at the glomerulonephritis patients, but with regards to our transplant population, what we did was we compared both devices to look at the HLA profile. Of course, if you're starting to develop new antibodies, that is a warning sign that you may be heralding antibody-mediated rejection soon. So what we did was we compared our devices to whole blood that was subsequently spun down using a Luminex HLA profiling. So our methods have already been described, but relatively simple. Patients had ethical approval and informed consent that was obtained, and subsequently blood or urine samples were obtained from patients, either those that had glomerulonephritis or renal transplant patients with a high CRF score, or those with high likelihood of HLA antibodies. 250 microliters of that sample was thereby placed onto one end of the biodesics device, left to incubate at room temperature for 5 to 10 days. And following a 5-minute period, the cassette was closed. I didn't mention before, but you can see over here, perhaps if I go back a slide, you'll be able to appreciate that this thing over here is a desiccant pack. And what it does is it helps to dry and thereby further prevent interference with the separation that happens over here. So once it had been incubated at room temperature on a flat surface for about 5 to 10 days, the latter half, the non-cellular bit, was treated in a standardized manner, reconstituted with 500 microliters of PBS, vortex, centrifuged for 3 minutes, and thereby the stuff that was left behind was analyzed using commercially available ELISA kits. So in the form of glomerulonephritis, we looked at urinary CD163, PR3 pathological antibody, PR3 antigen, and in the case of the transplant patients, was looking at HLA detection via Luminex. And all samples via biodesics were compared with standard laboratory blood and urine. As far as our patient group is concerned, we had 7 patients that had active glomerulonephritis. And in all 7 of these patients, we demonstrated, if you can look at the graph on the far left, raised levels of normalized urinary CD163. I use the word normalized because typically in the literature, CD163 is reported as a ratio of urinary creatinine, and a cutoff typically of 200, 300 is considered positive. So it was reassuring to identify that both in our biodesics group and those that were having standardized laboratory monitoring, that we were able to identify raised levels of urinary CD163 in those that had active glomerulonephritis. The one patient that was below this line was a negative control. Also reassuringly, somewhat concordance was identified between the biodesics device and standardized collection of urine. Although, as you can see, for 2 results, there was a difference between the urine and the biodesics, such that the latter results were less, but both of these results were not significantly different. Looking at our glomerulonephritis patients, again, we compared PR3 antibody on the left and soluble PR3 antigen, and again identified similar results using the biodesics device and laboratory serum, with no significant difference identified between either of these 2 groups. And then finally, looking at our transplant population, the graph on the table on the right illustrates in blue the biodesics population, and in red those that had whole blood collected via venipuncture and subsequent standardized laboratory processing. We had a total of 4 patients, and this is just one example of one of the patients, but these results were consistent in that we identified a similar antibody profile between the biodesics device and blood. So you can see CW112, CW112, CW2 is near the top, CW2 is near the top. So that was reassuring, although the absolute MFI values, which is essentially what quantifies the amount of antibody that you have, were quite different between the biodesics and blood, which pointed to us with regards to further work that could be done to optimize this, because obviously we went through a series of dilutions, and perhaps this factor needs to be corrected in the future when comparing with standardized blood. So our results definitely demonstrated promise of quote unquote a microsampling device, rather a blood collection device in monitoring biomarkers in patients with CKD, specifically those with a kidney transplant and those with glomerulonephritis. But obviously, our patient numbers are small, and further work needs to be done to validate this device in larger and more representative populations in different conditions, including different temperature settings and at different time courses. Nevertheless, we seek a lot of positive benefits and confidence with regards to these results that outline the potential positive benefits of microsampling as a whole in comparison to standardized microsampling techniques, to standardized methods of sample acquisition and processing. We've performed a literature review, and we've even focused on patient groups, both adults and children, and identified that as a whole, patients find these microsampling devices much more acceptable, much less painful in comparison to traditional means. Because in most cases, what they involve is a finger prick similar to blood glucose monitoring, and typically involve capillary blood, so much smaller volumes, which also has a benefit, particularly in the CKD population, in whom veins can, after years and years of venipuncture, become scarce and quite hard to find, and thereby also need to be preserved for fistula formations, which are necessary if patients are going to go on to hemodialysis, another form of renal replacement therapy. The fact that these microsampling sample acquisitions can be done very easily and remotely mean that a number of potentially disadvantaged groups are not disadvantaged, and particularly these include the elderly and the pediatric population, in whom venipuncture has traditionally been very, very challenging. Those that live far away, who often typically need to come to a central center and are often also thereby excluded from participating in research, and those that are disabled. Obviously, microsampling, by accessing or promoting access to care for these groups, promotes access to research and biobanking. And finally, there's been limited cost analysis studies that have been done, but those that have been done, to my knowledge, there's been 4, point to the fact that microsampling devices are also much cheaper than traditional means, mainly because of the fact that logistics of cold storage and centrifugation are minimized. There's not a need for phlebotomy staff, but also the opportunity costs and the time that is saved, and the society as a time, the impact that it has on minimizing time that you'd be spending away from work, leads to a number of cost-saving benefits. Thank you very much. I'm just going to pass on to my colleague now. Hannah will be presenting more on microsampling.
Hi, thanks. Let me just share my screen. Right. Can everyone see that?
Yep, that works, Hannah.
Okay, wonderful. So thank you, Cash. I'm afraid that my part of this talk is going to be a lot more data focused, which might be what you're into, it might not be. Just thought I'd give you some pre-warning. So my name's Hannah, and I'm a PhD student in the University of Liverpool, split between the Centre for Proteome Research and Alder Hayes Children's Hospital. So my project looks at proteomic analysis of microsamples. So right now that's dried blood spots for chronic kidney disease patients with pediatric focus. And the overall goals of my project are to identify and established and novel protein biomarkers, and basically getting us all to use remote sampling and preferably microsampling, as well as evaluating its utility for biobanking. My supervisors are Dr. Andrew Chetwynd, Professor Claire Ayres, and Dr. Louisa Oni, which is how I know Cash. So just my disclosures, I don't have any conflicts of interest, and my project is funded by the University of Liverpool and partially funded by Kidney Research UK. So I'll be looking more at the laboratory workflow and how we actually process these dried blood spot samples once we get them out of the patient's hands and into ours. So for me, that is from a proteomic standpoint, being based at the Centre for Proteome Research. So I thought I'd start with just a brief definition of what proteomics actually is, because I know that might not be something that necessarily everyone knows. So a good definition is written on the screen, but it's just proteomics represents the effort to establish the identities, quantities, structures, and biochemical and cellular functions of all proteins in an organism, organ, or organelle, and how these properties vary in space, time, or physiological state. Now that is a bit of a mouthful, and it's basically just saying that proteomics is the study of all proteins present in a specific pathway, system, cell, organ, or organism, basically whatever you want to look at, and then that group of proteins is referred to as a proteome. Now here, when looking at clinical samples, this can be broadly stated as the human proteome, and more specifically, when discussing dried blood spots, this is the human blood proteome. Now, proteomics is a wide and varied field, but my work focuses around the use of mass spectrometry, specifically liquid chromatography tandem mass spectrometry, in order to identify and analyze proteins in a sample. And I do this in the form of bottom-up proteomics, which just means that I break my proteins down into peptides before analysis. And the picture on the screen is of a nice little Q-Exactive HF, which is the mass spec I primarily use. So this might be of interest, it might not be, but here are just some general points about my workflow. So I use 10 microliters as my microsampling volume across the board, and I leave them to dry for about 2 hours. It takes longer when it's really cold and less time when it's really hot, just because of evaporation. But 2 to 3 hours is generally how long these 10 microliter spots take to dry for me. I then reconstitute my samples, which I'll get into a bit later. And then I reduce and alkylate them using a T-step and CAA step. And then I proceed into my sp3 digest with trypsin and lysine. And I do this all in 96 well plates with an N equals 5. All of the data that I'll be presenting here today is LCMS data from using the EVA set, which you can see on the screen, and a QX-HF or Q-Exactive HF on a 30 sample per day gradient using data-dependent acquisition top 18. All my data is processed using Proteome Discoverer, and all my data analysis has been done with a combination of R, Excel, and Prism. And those are just some housekeeping bits that are probably useful to know. So what are some of the difficulties that actually associate whole blood proteomics? Why aren't we all doing proteomics on whole blood? Most of the time when we refer to proteomic analysis of blood, we're actually referring to the analysis of serum or plasma samples, simply because they're far easier to process. A lot of this ease of use is due to the lack of hemoglobin, red blood cells, white blood cells in the sample. And if you aren't in proteomics, you might be thinking, why is this an issue, especially hemoglobin? So hemoglobin actually accounts for 95% of the protein concentration in the blood proteome, which is a large majority of it. And this is an issue in proteomics due to a phenomenon known as ion suppression. And essentially what this means is the processes that the ionization processes which occur in mass spectrometry that allow us to detect the peptides are competitive. So when you have a compound which is far more abundant, or a protein to be specific, that is far more abundant than the others within the sample, it kind of wins out on this competition. It makes it way less likely that you're going to detect lower abundance proteins, which are often what you would expect biomarkers to be. So the higher the abundance of the protein in a sample, the more likely it is to be detected, essentially. Now, we can't spin reconstituted dried blood spots down into plasma. Believe me, I've tried. It would make life a million times easier if you could. But the cells hemolyze and it's just impossible. And I don't know about you, but I don't have a centrifuge on my kitchen counter, so I can't be making plasma or serum samples at home to then make these dried spots, which would then make the remote sampling aspect of this null and void. But what we can do is optimize the proteomic workflow for dried blood spot analysis to minimize issues such as ion suppression and relating to hemoglobin and any other issues which we might find to get the most out of our dried blood spots. So the first question when considering whether remote sampling is a suitable avenue for your area of exploration is, can you see everything that you need to be able to see? So can you see as many proteins as dried blood as you would be able to in, for example, a wet plasma sample, which is what would be traditionally used in proteomics? So actually you do see a lot more, which is kind of what you would expect, as you've got the proteins from the red blood cells, the white blood cells, and the intracellular proteins. However, there is also a very low level of variation associated with this. And as you can see from the Venn diagram on the screen, the majority of the identified blood proteome overlaps with both plasma samples. And the missing proteins that we are seeing are probably due to this process of iron suppression due to the inclusion of hemoglobin. So you don't, in the comparison of blood v plasma, as far as the drying down process goes, you're not actually losing that many. However, then there is the question about the wet plasma sample, which is just the vernacular I'm using to refer to any sample that's not been dried down. So for the wet plasma samples, they have been extracted from the patient and then frozen, ready for analysis. So the next step would be to compare the wet plasma and the dry plasma. Now, you do identify slightly more proteins in the wet plasma samples versus the dry plasma samples. However, it's not like an incredibly large amount, and there was no significant difference in the protein ID numbers. And none of the absent proteins were necessarily interesting from a clinical proteomics standpoint, and some level of loss is inevitable, simply due to the fact that you're increasing the number of sample processing steps which are occurring. And whenever you increase the number of processing steps, you increase the opportunity for loss. Now, the volcano plot on the right shows the proteins which are significantly higher in either condition based on both their p-value and fold change. So the left-hand side of the graph shows the protein significantly higher in the wet plasma samples, and the right-hand side of the graph shows this protein significantly higher in the dry plasma samples. Now, most of the proteins more prevalent in the wet plasma were immunoglobulins and apolipoproteins, which are not necessarily interesting in proteomic analysis or in the hunt for biomarkers, because most of the time when you do proteomics on plasma samples, you deplete them anyway, which is something that I'm going to discuss later in the talk. However, it is worth noting that there were a couple of complement proteins which were significantly higher in the wet plasma samples than the dry samples. However, some level of loss is inevitable. The trick is trying to minimize the loss and prevent the loss of proteins which may be important or which may serve useful. So before I get back into the optimization of the workflow, there are some other considerations outside the actual process of method optimization that need to be accounted for. So an example of this is just comparing capillary and venous blood. Simply due to ease of use, a lot of my optimization workflow was performed on venous blood. And it can't just be assumed that this is then translatable to capillary blood without first testing it. Now, there were a couple of differences. As you can see from the Venn diagram on the left, initially more proteins were identified in the venous blood samples compared to the capillary samples. Now, this was somewhat expected because there is a higher level of hemoglobin in capillary blood than there is in venous blood, which can contribute to this iron suppression that I've been throwing around out there. However, once I filtered the data, so proteins present in fewer than 25% of samples, so a quarter of the samples were removed, more proteins were actually identified in the capillary than the venous. This said, the difference between the groups was fewer than 10 proteins, so had no statistical significance. So it can be concluded that really there's minimal difference between the two groups, and that the optimized workflow works for both venous and capillary blood samples. Now, you might notice in the volcano plot on the right that there were a few proteins which were significantly higher by fold change and p-value within the two groups. Now, they were minimal for the capillary, but if you're anything like me or my supervisor, you are looking straight at those 4 proteins in the top right-hand corner. They're fibrinogens and 1 coagulation factor, completely expected and consequential for the difference between venous blood and capillary blood. I've not, sadly, magically found a wonderful protein biomarker. So when looking at microsampling or remote sampling, there are a lot of companies claiming to produce the most foolproof and volumetric tool. Now, as far as clinical settings go, when you discuss microsampling, as Cash mentioned earlier, you're probably thinking of the Guthrie test, which is that test that they perform on newborns at 5 days old, little heel prick, get the blood, test them for 9 different metabolic disorders. Now, that uses either the Whatman 903 filter paper, which is pictured on the screen, or the Armstrong 226 filter papers. Now, although these serve their purpose very well, they are not a volumetric device. which means that due to varying levels of hematocrit within the samples, the blood spot spreads out different levels. So although you can punch out a circular dry blood spot of the exact same diameter and circumference, it will have varying levels of blood actually within the sample. Now, that's not really a consideration for clinical proteomics because the amount of protein injected into the mass spectrometers is standardized across the board anyway. However, depending on what you're looking at, that can be a key issue. So I decided to compare the Whatman 903 being the most commonly used standard filter paper used with two of the biggest dry blood spot devices named in the field, the Captana B10s and the Neoterix VAMS Mitra devices. Now, again, as I mentioned previously, I used 10 microliters across the board. And I actually found that there was very minimal difference, as you can see by the Venn diagram on the screen, between the identified proteomes using any of the devices. There was minimal difference in protein identifications. I think the largest difference in IDs was 23. So really, when it comes to your actual lab workflow, it's inconsequential which device you choose to use when looking at proteomics. So it depends what you prefer. There are several papers which show that the general public tends to find the Captana devices easier to use. And because my research focuses around pediatric patients, that is quite a high priority for me. And the reason why I continue to do the rest of my method optimization using the Captana devices. However, as far as the actual data output goes, there's minimal variation. Now, I'm going to go back to this whole dry v wet thing because I realise that might be a little bit confusing because you can't really analyse a dried glob on a page. So before I analyse them, I reconstitute these dry blood spots. So one of the first things I did was just to compare different methods of reconstitution and try and figure out the optimal way to get this dried spot back into a liquid media. So these all are results in dilute volumes of blood, as you start with 10 microliters, which due to the high concentration of protein within blood, it doesn't really matter that we're diluting it. So these methods range from reconstitution volumes of about 100 microliters to about 250 microliters. So still quite dilute. And I tested 5 different reconstitution methods in order to identify the optimal way to extract the largest protein quantities in the most efficient manner. Now, all of these methods were either directly sourced or adapted from literature, with all but the phosphate buffered saline, or PBS, as I'm just going to refer to it from here on, being originally intended for proteomic use. Now, as you can see from the results on this slide, using ammonium bicarbonate or phosphate buffered saline, you identified the largest number of proteins with the lowest level of variation for all 3 devices that I tested. So I tested this with the Captana, the VAMS, and the Whatman 903, which is shown on the graph on the left by C, V, and W. So those 2 far outperformed the other reconstitution methods, and you can see on the PCA plot on the right-hand side of the screen that they also clustered really nicely on top of each other, showing that they identified very similar proteomes. So a lot of the other methods did have far larger levels of variation, particularly the methods using tetrafluoroethylene and trifluoroacetic acid, or TFE and TFA. However, the papers that these methods were obtained for did look at higher volumes of blood. So they had a starting volume of 50 microliters as opposed to the 10 microliters that I had as my starting volume. So they just don't necessarily work as well for lower volumes. So based on my own results, I decided to continue using ammonium bicarbonate, or AMBIC, because it did just pip PBS to the post with the number of identified proteins, and the variation was that smidge bit smaller. And it's also, ammonium bicarbonate is used all of the time in proteomics labs. It's known to be very compatible with the rest of the methods that I was using, so I decided better safe than sorry. However, in a pinch, PBS would work as well. I would just recommend ammonium bicarbonate over PBS. So once I'd identified that ammonium bicarbonate was going to be the method that I personally was going to continue with, I decided to just test a couple of variations on this method to see if it could be further optimized. So the 200 microliter reconstitution volume incubated for 2 hours with gentle shaking was the method that I sourced from the literature. And then I decided to just alter this a bit, so reducing the reconstitution volume down to 100 microliters, and then incubating that for 2 hours, and then keeping the 200 microliters, but only incubating it for an hour. Now, as you can see from the graph, halving the volume of reconstitution media significantly reduced the number of proteins identified and increased the level of variation between the samples. So I scrapped that one, we're keeping 200 microliters. As for halving the time the sample was left for reconstitution, there was very little difference with the number of proteins identified and the variation within the sample groups. However, there were slightly more proteins found to be in significantly higher abundance in the literature conditions as opposed to the reduced time group. So when I incubated it for 200 microliters for 2 hours, there were more proteins which I would expect to be in higher abundance in that high abundance than there were in that 1 hour condition. Therefore, my conclusion was that the 2 hour condition gave me the most accurate representation of the whole blood proteome. And it was for this reason, and to allow time for the most diffusion of the proteins into the media as possible, that I opted to continue with the 2 hour method. However, if this optimized workflow were to be used for settings requiring higher throughput, for example, in clinical labs, I believe that using a 1 hour reconstitution method would have minimal negative effects on the samples, but in order to get the optimal protein output possible, I would recommend continuing with the 2 hour method. So I have touched on issues with iron suppression throughout this talk, and that kind of leads us to the conclusion that we want to get rid of some of the highly abundant proteins present in our dry blood samples. Now, although hemoglobin has been the main culprit that we've discussed concerning iron suppression, we're going to push that to the side. So 55% of, 55% of whole blood is made up of plasma, and 99% of the protein concentration of the plasma proteome is made up of 14 specific proteins, and these are globulins, fibrinogens, and albumins. So these are still vastly contribute to the proteome of your whole blood, and therefore to iron suppression. So there are quite a few different depletion kits which are sold and available. So by depletion, we just mean removing these highly abundant proteins in order to give us a better idea of what's going on in the lower abundance levels. So I chose to test a depletion resin sold by Thermo Fisher, which removes these top 14 most abundant proteins in serum. However, it didn't necessarily work out for me. Because it is designed for use on plasma or serum. It is not designed for use on whole blood, let alone whole blood which has been dried down and reconstituted in a dilute sample. So the kind of assumptions and conclusions that I've made are that the processing of the blood in this manner could be changing the morphology of the proteins present in their sample, probably their quaternary or tertiary structure. And as this depletion resin is antibody-based, the resin no longer is specific to these proteins. So what I found is that 90 proteins additional to the 14 that I was intending to remove were significantly higher in the undepleted samples than the depleted samples, as you can see by the volcano plot on the screen. So although it did increase the number of protein identification slightly, as you can see on the plot on the left, it also increased this wide level of variation due to the lack of specificity arising from these presumed morphological changes. So I would not recommend using a serum or plasma intended depletion resin or depletion product for proteomic analysis of whole blood spots, as it could and probably would impact the reliability of your results. So the next question would be to discuss depletion of hemoglobin, but that's kind of a work in progress situation that you may hear about in the future. So this is just a graphic that I created, which, to be honest, I'm very proud of, to give an overview of this process. So we start with a finger prick, and you add that to your device to dry. You leave it to dry 2 to 3 hours if using the 10 microliter spots, and then you can simply remove your sample and then store it, transport it, whatever is your desire. That's the wonderful thing about these microsampling. They make it possible to do this remote sampling, and then so take your samples at home and then ship them to wherever they need to be analysed. And once you're ready for analysis, you simply reconstitute your sample in 200 microliters of ammonium bicarbonate, for 2 hours with gentle shaking. How many times can I say that statement? You can then digest the proteins and prepare them for proteomic analysis. So again, for me, this was reduction and alkylation with TSEP and CAA, then an sp3 digest, and then acidifying my sample, preparing my EVA tips, and whacking it on the QXHF. So what are the future directions from this? So personally, I will be applying this method to CKD and IgAV patient samples. So I've got some preliminary data from chronic kidney disease patients, and in the dry blood spots, we're finding that the presence of C-reactive protein is 22 times higher in the dry blood spots of the chronic kidney disease patients compared to the healthy controls. So that works back into our search for biomarkers, which is what we're all here for. I will also be translating this method to work with dried urine, which is massive when discussing kidney impairment, saliva and tear samples. So it's unknown what that method's going to look like, but that's the next step. And I also have an ongoing stability study exploring how long you can store these dried blood spots for at 4 degrees and 21 degrees up to a year. So basically, how stable are they once they're in this dried form? And the possible uses of this are widespread. So I know Kashif touched on some of them, but for biobanking and specifically longitudinal samples where you're following patients over a prolonged period of time in order to test for different things in their blood, meaning that they wouldn't have to come in to the hospital every single time they needed to provide these samples, especially if they live in remote locations, is a massive implication. So here are just some references. And again, thanks to my supervisors and the Institute. And thank you for listening. And I believe that means we're up to question time.
Thank you, Hannah, and thank you, Cash. Cash, if you can come back on camera as well, please, that'd be great. So, thank you for those fantastic presentations there. It's really, really interesting. For those watching online, if you can submit your questions through the chat function, please. We've got 10 minutes or so to go through some questions, so it's a little bit of time, which is good. So I've got a question here for you, Cash. Is Biodexis a quantitative microsampling device? How much volume do you collect, and how much is the volume precision?
Thank you. Thank you for that question. It's a good question. Let me just share. I don't know if this diagnostics. This comes through. Does this diagram come through?
Yes.
Amazing. So this was the work that we did was a proof of concept preliminary piece of work on the utility of microsampling in adult kidney patients. An idea similar to many research ideas that almost feels like a bit of hard work and good fortune and good luck combining together. Myself, my supervisor, we had no previous expertise or experience on microsampling devices. So the results that we have gotten have been certainly reassuring, but yes, there's a lot of work that we can build on from this. In answer to your question, the Biodexis device itself does not collect blood in a volumetric manner. So it's not a VAMS. And what happens is from sample deposition onto the actual filter paper, all the way through to until you have the final sample that you can place into your ELISA, for example, there's a number of things that can influence what is your final sample. So we've mentioned obviously that this is not volumetric. So there may be hemoglobin concentration or hemoglobin large accumulation in the blood that exaggerates a volume for one patient in comparison to another. Thereby, we hope that this process of lateral flow works fine. But if it's not homogeneously distributed, there may be more red blood cells on one side versus the other. And the mesh is supposed to prevent that from happening. And thereafter, once we've got this cellular, non-cellular separation, we cut up our sample. We didn't use typical punch holes that have been used in previous uses of dried spot tests. But what we did was we standardized our method of cutting up this paper, reconstituting with 500 microliters of PBS and spinning it down. And then what we were left with at the end was a sample. I guess reassuringly, despite not being a volumetric method, the results that we got, or the analytes that we were looking at, didn't seem to be affected so much by a hematocrit effect or hemoglobin concentration. So I hope that's answered your question.
Yeah, it's great. I'm really intrigued myself. This is my own question and comment, because that device, the Patient-Centric Sampling Interest Group has an extensive listing on its website of all the commercially available devices, and that device isn't on our list. And I looked up the website and I can't find it. So I'm intrigued how you managed to buy it.
So, like I said, complete serendipity. I'm not sure what the conversations were before I hopped onto the project, but by then a grant had been secured. I suppose this was one of the devices that they probably came across. We didn't know much about volumetric versus non-volumetric. We didn't know about CME mark devices. So this was, like I said, our preliminary early proof of concept work that has given us some confidence. The further work that we're going to be looking at, similar to what Hannah's doing, is actually looking at capitainer devices and VAMS mitra devices, which obviously do fulfill some of these standards that you're speaking about. And we're going to be looking longitudinally at similar populations and using different storage conditions. So hopefully that might give these results perhaps a more solid layer of credibility. But yeah, I suppose serendipity upon stumbling upon this.
Yeah, it's just, it can't be found on the internet. It's interesting.
Well, they gave us a huge box of them, so.
So I have another question here, and this can go to either you, Hannah, or yourself, Cash. Any practical concerns regarding using finger prick sampling versus other peripheral blood collection devices, i.e. microneedle devices, especially for pediatric studies? So I think what they're saying is there are other technologies out there that don't use finger pricks. They can be placed on the arm, the thigh, the buttock, the back. Just particularly for pediatric studies, is there any concerns of finger prick versus maybe using other technologies? And are you going to consider looking at non-finger prick technologies?
Hannah, do you want to start with this?
So I'll start, and then as far as the clinical questions would go, that's not my area of expertise, so I'll move it on to you then, Cash. But I would say that finger prick sampling is not, although it can be very difficult, it's not as alien of a concept as some of these other ones, so it tends to be a bit more acceptable. And I know as a child, before any of these were a thing, I remember having my capillary blood taken through a finger prick that they just squeezed into a bottle. So it is a very well-established method of blood collection. I think that looking at different peripheral blood collection devices is very interesting and probably something that I will do at some point. However, for its common use as of right now, finger prick sampling just makes a lot of sense, and especially with its compatibility to these existing dried blood spot devices.
Okay, thank you. I've got another question here. Are you going to be collecting data from patients and clinicians as to their response to doing this? So you're obviously very early on, and I think, Cash, you talked a little bit about generalized patient acceptance, but do you have any specific data, or are you intending on collecting data for your specific approach from clinicians and from patients?
Yeah, so at the moment, like you said, it is very preliminary work, and we're still trying to show that it does show concordance with standard laboratory techniques, but simultaneously we have looked at its acceptability and the perceptions that both adults and children have with regards to microsampling. We've published both of these. Rather, actually, the pediatric one has been published. The adult one has been sent for publication and is being looked at. But in essence, these devices are in both populations very favorable. In our adult cohort, we looked at 87 respondents via an online Kidney Voices for Research forum, and the vast majority, 90% plus, expressed willingness to provide dried blood and urine samples, in addition to samples that they would normally be providing for their usual clinics. 70% rated the discomfort as low, and more than 2/3 felt that at least a monthly frequency was appropriate. Similarly, in the children's cohort, we focused on a young person's advisory group led primarily by my Liverpool colleagues, in which 13 children between 10 and 17 years of age were focused on. The format of this was that an online demonstration was provided for one such device, the Neoterix, followed by a group discussion focusing on the pros and cons and how to correctly use this device. And thereby a survey was completed, and we found that 90% felt microsampling was preferential to traditional collection methods. 90% felt that they were keen to provide blood samples despite the finger prick. All 100% felt that at least monthly collections was a suitable frequency. And 80% interestingly felt that use of such devices would increase research participation. Now, you're right. That's one half of the equation, the patients that we're actually going to be focusing on, perhaps clearly the most important group, but the clinicians and the laboratory staff that are going to be actually analyzing this, and the researchers, what is their perceptions? That's a piece of work that we haven't done, but surely we'll be following on from our work.
Oh, thank you. That's really helpful. I think we've got time for one last question for Hannah. For the detection of blood biomarkers, does normal LCMS work, or do we need to switch to high-resolution mass spectrometry?
So as far as more established proteins that we would look at for inflammation and chronic kidney disease, such as complement proteins, and I mentioned C-reactive protein earlier, they were all detected just with normal LCMS. I've not experimented with HRMS yet. That's one of my next steps, but it will be interesting to see. But as far as the established ones that we know about as of right now, we're picking up on them fine, just using normal LCMS.
Okay, thank you. Quick question. Did you apply exactly 10 microliters to the Capitainer devices, or did you actually apply a higher volume than 10 microliters?
So I applied a higher volume than 10 microliters, as the Capitainer B10s have a discard pad underneath, which will accept any excess. So the capillary only allows up 10 microliters of blood. So I added 20 microliters of blood and found that it was all working fine. As far as I can tell, 10 microliters of blood is in the sample patch. About 1 microliter is in the remains in the capillary, and then the rest is in the discard sample.
Okay, we don't have any time. I can see there's some more questions coming in late. I'm afraid we've run out of time on our hour now to go through any more questions. I'd like to thank Hannah and Cash for a really, really interesting presentation. Before everyone leaves, I'd just like to do a couple of a plug for our next webinar. The next patient-centric sampling webinar is on the 18th of June. We'll be bringing you to Tatiana Dobreva from IMU, talking to us about patient-centric sampling of capillary blood provides unique biological insights into autoimmune flares. So please register for that if you're interested, and obviously it will be available on demand after the event, as will all of our webinars. If you're interested in joining the patient-centric sampling interest group, bringing together different parties interested in breaking down the barriers to the understanding and more widespread adoption, please take a look at our website using the QR code on the left. You may want to join our LinkedIn group using the QR code on the right. Please do. The more people we have involved in our group, the more activities we can get involved with. Finally, I'd like to thank all of our sponsors again, whose generous donations make it possible for us to provide these webinars for free. And finally, just like to thank our speakers again, and for another great webinar, which will be available to view for free in a few days' time. Thank you all, and we'll see you next month.